Up next, we are welcoming back Dr. Mike Allison. So, Mike is UMEM alumni. He completed our EM critical care program in 2015. And then we were fortunate enough to keep him in the state, not necessarily within the Maryland program, until a little bit more recently when he moved over to St. Joe's. So he is currently the chief of the critical care division over at the University of Maryland, St. Joe's Medical Center, where he does an incredible amount of stuff administratively and clinically in their ICU. Mike is going to talk to us about what we need to know with respect to high flow. Based on literature, it certainly is something we're using very frequently in the resuscitation of critically ill patients. Mike, welcome back to UMEM.
Thanks, Mike. I'm looking for the clicker. Maybe Dr. Wood has it. Sam, that was awesome.
Thank you.
Such a great talk to lead it off. And then I have to follow. Good morning. Thanks, Mike. Thanks, Mark, Cami, Doreen, for putting this together, for the invitation. Um, nice to see you all. It's really good to be back. I don't have any disclosures, but I did want to thank a couple of people who were instrumental in my training. The list is super long, so I had to narrow it down, and I chose a couple of current events to help me narrow the list down. Happy birthday, Ken Butler. His birthday was yesterday. Happy belated birthday, Ken Butler. Want to recognize an amazing career for Brian Earl. I hear his retirement is forthcoming. So Brian Earl. And a huge shout out to Residency Program Director Extraordinaire Sarah Dubbs. Thinking of you, Sarah. All right. All right, for the next 20 minutes, I'm going to tell you a couple things that will change your life. All right, probably not. That was Sam's work. Sam did that. But what we'll go over are some really key tips and tricks and knowledge that you will apply on your very next shift to apply nasal oxygen in a way that's going to help patients. I'm going to start with the take-home points. So if you want to pay attention for the next 4 slides, then tune out, then come back, you're going to get it. First, high flow will physiologically change your respiratory mechanics. It is not just oxygen delivery. I'll tell you why. High flow should be used for hypoxemic respiratory failure, and there's a way to monitor it using the ROX index. We'll talk through that. High flow can be an apneic adjunct, emphasis adjunct, during intubation. Your preox is what matters. And high flow can be used in patients with pulmonary edema and COPD selectively. That's the key. So the beginning is going to talk about some of the physiology and mechanisms of high flow. Then we're going to go into the evidence and the applications. Let's start with physiology. Oxygen dilution. I think this will be a bit straightforward, but when you're quiet, resting, breathing, like you all are right now, your peak flow, remember your inspiratory flows are going to vary. Your peak inspiratory flow might be 15, 30 liters. My peak inspiratory flow right now is probably a little higher. If you're in respiratory distress, some of the marathoners in the room, when you go run your training runs, your respiratory peak flows are going to be higher. That patient in the ED with respiratory distress, they're exceeding 60 liters per minute of peak flow. Not total flow, peak flow. So when you apply a low flow oxygen device of 100% oxygen at 6 liters per minute, that patient in respiratory distress is entraining 54 liters per minute of room air. It's diluting your oxygen out. So how do you combat that? You put on high flow. You turn up the flow to 50 liters per minute. And for that patient, that example of a patient who's taking 60 liters per minute of a peak flow, you're matching their respiratory flow effort much better, reducing the oxygen dilution and reducing the room air entrainment. So it's more consistent and reliably delivered FiO2. Everyone wants to talk about positive pressure. It's fallen out of favor, but about 10 years ago, everyone was calling high flow CPAP light. 15 years ago, some studies were done to look at the positive pressure effects of high flow nasal oxygen. Took not animals, took humans, put in a nasopharyngeal catheter, pressure transducer at the distal tip, applied high flow at various flow rates. The bottom line from a couple of studies that did this, with mouth closed breathing, you can have an end expiratory pressure that approximates 4 to 6 centimeters of water. Open the mouth, no surprise, that pressure is going to decrease down to about 1 centimeters of water. But what we really want to know is what is the pressure delivered to the airways? So, getting a little closer, sort of a novel investigation for patients that were inpatients with tracheostomies who were going to be decannulated in the inpatient setting. They were included into a study. They measured tracheal pressures at various flow rates of high flow. And they ended up finding that about 2 centimeters of water is the transduction of tracheal pressure with high flow. I'm pretty sure this was at about 45 liters per minute of nasal high flow. So what you're seeing is that there's a slight positive pressure. It's flow dependent. Lower flows, lower pressure. Higher flows, higher pressure from high flow. But it's not CPAP. It's not BiPAP. Let's talk about washout. You all know that we have anatomic dead space. That last breath, that carbon dioxide that sits in our oropharynx and our upper airways is full of carbon dioxide. So that next breath in, where our first breath, the first gas that's entering our lungs is carbon dioxide again. Apply high flow nasal oxygen and you've got oxygen containing space. So that next breath becomes easier, delivers a lower respiratory rate, and helps improve work of breathing. Again, flow dependent, lower flow rates, lower washout, higher flow rates, higher CO2 washout. The best physiologic study was published in the Blue Journal 8 years ago. This took 15 patients. These patients were sick. About 7 of them had P to F ratios less than 100. They were not intubated at the time. They had bilateral airspace disease. These are representative patients, I think, of the patients with the diseases that we're going to treat with high flow. And what they found by application of high flow as compared to application of a face mask was improved pressure time product. You all know that one, right? The integral of the respiratory muscle work over an inspiration breath, right? The area under the curve of that. All right. So that's the calculation. When you say work of breathing, that's the math. The pressure time product is calculating the math of your work of breathing. So that was reduced, improved work of breathing, mathematically improved. Minute ventilation reduced by a reduction in respiratory rate. Dynamic compliance improved, went up, and end expiratory lung volume increased. So increasing that FRC. So there is some recruitment. And these are in really sick respiratory failure patients. So I think we've got a pretty good body of literature showing that physiologic changes happen with the application of high flow. It's different than your traditional nasal cannula. It's different than your face mask ventilation. And you're not just delivering more oxygen, you're making physiologic changes to that patient. So, based on that, we should expect some improvements and some applications that would see benefit. The next shift you go on, or perhaps this is a throwback, a couple of years ago, 54-year-old SARS-CoV-2 on 6 liters per minute nasal cannula. They look all right. They're talking. Nurse comes and gets you. They've desaturated. What's your next move? And I hope that by now, most folks in the room are going to say, we're going to move to high flow nasal oxygen for this patient. The seminal trial conducted in 2015, the FRAT trial called Flurali, was a randomized controlled trial, 3-prong, looking at conventional oxygen therapy, which I just call nasal cannula, conventional oxygen therapy, high flow, and NIV. About 100 patients in each arm of this trial, and they're looking at 30-day intubation rates for their primary outcome, secondary outcome, 90-day mortality. What did they find with their primary outcome? No statistically significant difference between high flow, nasal cannula, and NIV. You can see the numbers just slightly misformatted there. P-value is not significant, but they really wanted this to be right. They wanted high flow to be right. So what did they do? Subgroup analysis. Subgroup analysis of all of these patients with P to F ratio less than 200. So take out the not so sick ones, throw in only the really sick ones, and intubation rates lower in high flow. secondary analysis, subgroup, post hoc, grain of salt. Um, Looking at mortality, this was the number that ended up getting this study published in the New England Journal. Mortality rates in high flow were statistically significantly lower in the high flow group compared to conventional oxygen therapy and non-invasive ventilation. A couple of theories of why this was. Non-invasive group didn't have volume limits, so they could have had injurious tidal volumes during the trial. But here, high flow was a statistically significant winner. So based on this, I would say that high flow is routinely used for hypoxemic failure. I almost put those crazy words, standard of care, but who am I to put that on a slide and call it standard of care? But it's probably close. You're probably going to see it in guidelines coming soon. So I'm just going to go with routine for right now, but know that that's going to be what you're going to do for this patient the next time you see them on shift. But you know what's going to happen. You're early in your shift. An hour later, they're still boarding. They're there. They're now up to 50 liters per minute, 60%. What are you doing? How are you going to sniff out failure in these patients? There's all the standard stuff that you're going to do. Your type 1 thinking, you're going to go in the room, you're going to look at them, and much of your type 1 thinking will end up telling you this patient's going to fail. But what about those cases that are sort of gray zones? The ROX index was created, studied almost a decade ago now, looking at respiratory rate, the SpO2, and the FiO2, finding that the combination of these metrics was superior to any one alone. And how do you calculate it? You might be familiar with your P to F ratios. So you're going to take an S to F ratio, SpO2 to FiO2 ratio, and divide it by the respiratory rate. Greater than 4.88 in this first trial was predictive of success. So who's got a phone out? Someone's got a calculator. Patient is saturating 94%, 94. We are dividing by an FiO2, what was the slide? Was it 60? Divide by 0.6, and their respiratory rate is 30 breaths per minute. Kind of concerning, on the borderline. Do that math. What do you get? 5 point something? 5.2? I heard some sixes. 5.2, I think, is the answer. So that's a patient that, with time, you should plan for high flow nasal oxygen success. In the emergency department, I think what we might be a little more concerned with is what's going to go on with respect to failure. And a subsequent study looked at high flow nasal oxygen used for this very purpose in patients with acute hypoxemic respiratory failure, validated through an analysis using the Florali subgroup, actually. So prospective study of new patients plus Florali patients retrospective to look at values, and found that failure in a time frame of less than 2 hours was noted with a ROX index of less than 3. Let's round it. And in 6 hours, a ROX index less than 3.5. I think that this is not going to be so helpful because you're already going to know. Calculators out. The patient is saturating 88%. They are on an FiO2 of 90%, 88 divided by 0.9. Their respiratory rate is 35. 2.7. You know that patient in 2 hours' time is not going to be doing well. So I think the ROX index is a nice way of framing respiratory success and respiratory failure with high flow nasal oxygen. I find that more often than not when I'm calculating it, I get values in the middle, and then it's trickier to determine. And so you have to use that great thing, clinical gestalt, to treat your patients. But in this case, this patient that you're seeing is pretty clear. ROX index is low. You have an hour left in your shift. Now what are you doing? NIV, hands up. Intubate, hands up. Intubate wins. Okay, so are you going to intubate with your high flow in place? Hands up, yes. Hands up, no. I got a different plan. So this is kind of confusing. And I want to go through all of this literature. And it's really hard to keep this literature straight. So when you're intubating, you have a pre-oxygenation period And then you have the apneic oxygenation period. And so there's a variety of studies that tried to look at apneic oxygenation, but what they didn't do a good job of was keeping pre-ox. First study that I looked at in 2015, the Miguel Montañez study, looked at high flow versus non-rebreather pre-ox, and then high flow continued during apnea, non-rebreather off, and found a benefit to apneic oxygenation in this study population with high flow. So this was a positive study pro high flow. But then you've got a couple other studies. This is the pre-OptiFlow study, I think it was named, high flow versus a face mask pre, and then apneic oxygenation with high flow versus no oxygen. Let me go back to that first study because I misspoke. They were actually the ones that put 6 liters of nasal oxygen on during apnea versus high flow. The rest of these trials, as you'll see, just took the oxygen off and had no oxygen during apnea periods. The Simon case did the same thing with a bag valve mask as pre-oxygenation versus high flow. The Semler trial, this is the Fellows trial. This one made waves, and some of the blog articles that you would read say, "Is apneic oxygenation dead?" Right? So that's how big of a deal this one was. This was a randomized controlled trial. The pre-ox was the same. So we're really just looking at apneic oxygenation here. And the interesting finding, which is why people were contemplating whether it's dead, is that there was no benefit in this particular study to apneic oxygenation with high flow compared with no oxygen during intubation. Their success rates were pretty good. The intubations were conducted by trainees and some attendings, single center in Vanderbilt. So if you would go off the best literature to date, you would go off of this and say, maybe high flow doesn't have a clear statistically significant benefit in apneic oxygenation. A couple more studies try and look at this same thing. The last one, Jean-Pierre Frat, the Florali 2 trial was looking at high flow versus NIV, but again, no apneic oxygenation in the NIV group. They did find benefit in that high flow group. So my conclusions on this, you have to pre-ox with NIV, and the pre-ox is what matters. And I will fully admit here that when I am intubating patients in the emergency department, in the ICU, that I'm not always using apneic oxygenation with high flow nasal oxygen. The sick ones, I might do it. Where I am, usually they might be on an NIV machine for non-invasive, have a ventilator in the room, and then though the ventilator can give high flow, usually the respiratory therapists are rolling in a third device, so it becomes crowded in there. So I think there's a logistic problem with doing this for every patient. So my recommendation and what I do in my practice is selectively use high flow for apneic oxygenation, but I am nearly universally using non-invasive per pre-ox. All right. There's only an hour left, but you got one more to see. There's another one in the box. And here is a patient with respiratory distress and wheezing. You look through the chart, history of COPD. So here's the big question for this one. What are we going to do with respect to high flow nasal oxygen? Can we just put that on? We know they're going to pull off the non-invasive mask, right? You've all seen it. Then you're talking about Ativan, you're talking about Precedex, maybe you're talking about ketamine. So can't we just use some high flow? I think the Renovate trial can help us answer this question. They call it the Renovate trial. I call it the Jack of all trades trial. Because what they really tried to do was look at a variety of different respiratory failure groups. They looked at hypoxemic respiratory failure, both immunocompetent and immunocompromised. They looked at COVID-19. The study started in 2019. COVID came. They decided, oh, we need another group. So they put everybody into a COVID group that had that diagnosis. They looked at acute cardiogenic pulmonary edema and acute exacerbations of COPD. Here are the findings. In hypoxemic respiratory failure in the immunocompetent patient, this confirms the findings from Florali that we are safe to use high flow nasal oxygen, non-inferior to non-invasive ventilation. Not superior, non-inferior. In the immunocompromised patients, a very small sample size and some a priori assumptions were made. And so on the first check, it was stopped for futility. If you look through this trial, you see the absolute difference in intubation or mortality within 7 days was higher in the high flow group. And so they stopped this for the immunocompromised patients. I think this is not the end all be all, and I'm not recommending that you not use this in your immunocompromised patients. I would say that in immunocompromised patients, there's slight data favoring non invasive ventilation based upon this particular trial. There are others that show general equivalence for that group of patients. Now to acute cardiogenic pulmonary edema and acute exacerbations of COPD. Uh, where to begin? Acute cardiogenic pulmonary edema, you've seen it. You've seen EMS bring these patients in on non invasive ventilation, on CPAP, into your emergency department. All of those patients were excluded from this trial. So it's automatically excluding the most severe cases of cardiogenic pulmonary edema. That's one. For COPD, for the COPD group that was randomized to high flow nasal oxygen, those patients who are randomized to high flow nasal oxygen, um, excuse me one second, ended up having over 20% crossover to non-invasive. So many of those patients crossed over and intention to treat analysis, they were analyzed as they were randomized. Lastly, who are the statistics gurus here in the audience? See Dr. Whitting. All right, I need audience participation on this. When you are conducting hierarchical Bayesian analysis, do you use random borrowing? Absolutely. No hands. Okay. When you use Bayesian analysis, hierarchical Bayesian analysis, do you not use dynamic randomized borrowing? Okay. It's important. Very important. The way they did this was with dynamic borrowing. And when you do dynamic borrowing, you're assuming some level of homogeneity between groups, which I think obviously there's not. And so when you do the dynamic borrowing, you find non-inferiority for these groups. In a secondary analysis, they said, let's stop the borrowing. Let's analyze it traditional Bayesian. And that finds the probability of harm in acute COPD and acute pulmonary edema. So I think the jury is not out here, and I would emphasize the selective use of high flow nasal oxygen in these patients based upon that statistical analysis. The statistics mattered in this case, and I think it creates possibly a bit more confusion. So let's take it home. You all know that high flow is not just oxygen delivery now. It's going to change your patient's physiology. You know that high flow is going to be used as your first line for hypoxemic respiratory failure. Monitor it with the ROX index. Low values predict failure. I didn't mention this before. The specificity of those numbers was 99%, with 99% specificity. Higher values suggest improvement and monitoring, and the patients may succeed. High flow can be an adjunct during intubation. Preox with NIV, high flow as an apneic adjunct, specifically in those really high-risk patients. And high flow can be selectively used in patients with acute pulmonary edema or acute exacerbations of COPD. The way I use it is I might start with my NIV or my CPAP or BiPAP, and then if the patient wants the mask removed, needs a break, you can feel comfortable moving to short periods of high flow nasal oxygen in those patients. It was great to be back. Thanks so much. I'll take your questions.
Much, Mike. I'm going to stay over here and go to Eileen for questions from the chat. Oh, yeah.
Yep, we do have one question for you. In your actual clinical practice, how often are you reaching for your calculator and calculating that ROX index versus just using your clinical gestalt?
Tricky patients. I'd estimate probably, 25%, one in four. Um, I think it becomes clearer the more time you use the ROX index that the patients who succeed are going to have significant reductions in respiratory rate, driving that denominator down. So the higher the respiratory rate, the more likely failure.
Dr. Hasi.
Dan, you get two.
Okay. I just have one question, and it's a kind of a niche question. So, the ROX index uses SpO2, and there's been good literature to suggest that patients with darker skin tones have wild inaccuracies with their pulse oxes. How frequently do you use an initial EBG to correlate your pulse ox with the actual PaO2 of the patient?
Great question. And I think that's a flaw of the existing literature that needs to be addressed. I think when I'm getting an ABG, I'm looking in my severe cases, the cases that are in that gray zone that might have a ROX index of 3.3 or 3.4. They're not clearly failure. They're not clearly going to succeed. I will get arterial blood gas analysis for those patients.
ABGs.
Dan said it.
Additional questions? All right. Thanks so much, Dr. Allison.
Thank you.